I should start talking about.
Yes.
My medical training started at Harvard Medical School, which I graduated in 1957. And then I trained in internal medicine at one of the Harvard teaching hospitals, Beth Israel in Boston, and in neurology at the Massachusetts General in Boston. Then went to the National Institutes of Health for 2 years doing brain physiology, brain research. Did another residency training in psychiatry in New York at Columbia Presbyterian Medical Center. And then over the following 5 or 6 years, got very involved in working in drug addiction. And by 1974, was the city addiction commissioner and ran all the programs that the city funded for addicts. Then in '78, the governor and the mayor met, and the governor took over management of the city's addiction programs because the city was in a budget crisis, and it was Mayor Koch saved about $8 million. And I moved to the city health department, and as a deputy commissioner, was the only medical deputy commissioner, and basically ran the city health department for about 3 years. Then I moved to Kings County Hospital, where I ran a cluster of addiction programs for drug addicts and alcoholics. And by the early 80s, as the AIDS epidemic began, I got very concerned about it. I was seeing large numbers of the heroin addicts I was treating die. And I had a couple of friends with HIV who died in the late 80s. I got very concerned about what I saw as a major epidemic, worldwide epidemic coming over time. And that's sort of a background, taking me up to the point where I started doing this research.
Now, did you tell me once that you had something to do with methadone?
Yeah, I started, my first job in city government was running all of the city health department's methadone programs. There were 41, shortly after the methadone system had been put in place. And it was while I was doing that the mayor, was then Abe Beam, moved the addiction services agency into the health department. And I took over management of all the addiction programs, the drug-free and the methadone programs at that point, and ran both for about 4 years.
But it's not like you had you found methadone.
Oh no. I was one of the early people. I was one of the early proponents of it, and because of my job in city government for a couple of years, was a major spokesperson for methadone, which I've since had much more in the way of mixed feelings about. But then I became more broadly involved in drug addiction and alcoholism, and as a public health problem, and then shifted my energy to AIDS later.
So how did your connection with naltrexone come about?
Well, in 1984, the National Institute on Drug Abuse finished the development of naltrexone as an adjunct in treating heroin addicts. Its purpose was to block the heroin high, and with the hope that it would become a very useful treatment for heroin addicts. It works in heroin addicts by blocking the receptors on cells, mostly in the brain in that situation, that heroin uses to, primarily the pain receptors. They're all called opioid receptors, but those that are involved in pain relief and relief of fear. The drug it's a designer drug, really, that was designed in the laboratory to block those receptors and prevent heroin from having access to them. So addicts would take 15 milligrams a day in the morning and couldn't get high for hours. would take a very large amount of heroin to overcome the high, the blockade caused by naltrexone. And when the drug came out, I was interested in trying it and gave it to about 24 heroin addicts who had recently stopped using heroin. And none of them would stay on it. At the doses involved, it caused anxiety, depression, irritability, they couldn't sleep, and even minor stresses that they could handle the day before, they couldn't handle on days that they took naltrexone in the morning. So it was out on the market, and has remained so since, but has been relatively little used. And one of the things I did know from its development, which I'd followed closely because I was treating addicts, was that naltrexone, when taken in these high doses, would get the body to triple its production of endorphins. Endorphins are the hormones that heroin works by mimicking. And they have a number of functions in the body. They relieve pain, they relieve fear. They're the hormones we use as we learn, when we're teenagers, when we learn to cope with social situations and other anxiety-producing situations. It's really endorphins that relieve the anxiety. They also play a major role during acute stress. For example, an animal who's attacked in the jungle his body responds by pouring out large amounts of endorphins and in parallel of cortisol, which is a cortisone related hormone. And the endorphins in that situation not only relieve pain so that the animal gets injured, he's not distracted, they relieve the fright. They also shift blood from the whole gastrointestinal tract, where a lot of the blood flow is, to the muscles and brain, which need it during a fight. And most importantly in this situation is they boost the immune system so that the immune cells double very quickly, and immune functions all improve with the large amount of endorphins poured out, so that if the animal gets injured, it's less likely to get infected, and so that the wound will heal more. There'll be better wound healing. And that's because of its role in regulating immune function. I got interested in it in the mid-'80s, in 1985, as I saw the AIDS epidemic expanding. I decided to shift my research energies from addiction to AIDS, and in particular to look for something that might boost immune function. And I knew that the immune system was regulated almost entirely by endorphins, and that also that the endorphin production was markedly increased by naltrexone. And my colleagues and I worked to find some way of using that ability of naltrexone to raise endorphins, but without the downside of naltrexone blocking the endorphins. And the purpose being to find a way to raise endorphins to boost immune function. Along the way, we tested endorphin levels in 10 people with AIDS and found they were extremely low, less than 30% of normal. And so the hormones that people with AIDS need the most just to have the immune system fight the virus, those hormones are lacking. And so what we did was to do what's called a dose ranging trial to find the best dose of the drug to use to raise endorphins without blocking them at the same time. And one of the principles, let me ask you, should I look at the camera or at you? Does it make a difference?
It's best to look at the camera.
It is, okay. Because it's a little harder to talk to a blank little,
Yeah,
but I will.
I can see you through.
Yeah, okay. one of the what we did was we measured the endorphin rises with different doses of naltrexone, and we got the same rise with 50 milligrams, 20 milligrams, 10 milligrams, 5 milligrams, and 3 milligrams. 1 milligram produced no effect at all. What we were looking for was the smallest dose that could produce a full endorphin, naltrexone-induced endorphin rise, if taken late at night. The reason the hour is important is that 90% of the endorphins are made in the middle of the night, between 2 and 4 in the morning. And if the small dose of naltrexone is taken in the late evening, generally at bedtime, endorphin production is boosted as much as threefold, 300%. And the naltrexone itself is gone in about 3 hours, but the endorphins remain elevated all the next day. And so the naltrexone doesn't really significantly block the endorphins, but does cause them to rise. If somebody with low endorphin levels starts taking naltrexone every night, low dose naltrexone every night, their endorphin levels will triple and stay tripled as long as they're taking the drug. And the first thing we did then was a placebo-controlled trial in people with AIDS, in which half of the patients got the drug and half got a placebo, and we didn't know who was getting what. We started a foundation and raised a little less than $1 million to do the trial. And the trial took about 9 months. And at the end of the trial, it was clear that the people on the drug, once we broke the code, people on the drug were doing much better than people on the placebo. They had many fewer deaths, many fewer of the major opportunistic infections that are the cause of death, people with AIDS. Their immune system cells, particularly the T helper cells, which are the ones most damaged by HIV, dropped significantly less in people on the drug than on placebo. And it looked very promising. In the course of the trial, I got a call from a friend who was experiencing a recurrence of her lymphoma, which had been treated, a non-Hodgkin's lymphoma, had been treated 5 years earlier with chemotherapy, which had produced a remission. And then 5 years later, while I was doing this trial, she had a recurrence. And her husband had just died, prostate cancer, and had had a lot of chemotherapy and been quite ill with it. And she had very negative feelings at that point about chemotherapy. When her oncologist suggested that she get another round of chemotherapy, he also told her that her tumor was much less likely to respond than it did the first time, because lymphoma in particular tends to mutate against chemotherapy, so that the second round of treatment is not as effective as the first. The third is not as effective as the second. She called me and said, literally, do you think that your AIDS drug would help my cancer? And I just read a paper in which mice had been injected with human lymphoma cells. It's a breed of mouse that does not reject human cells because of its own immune system. And in this study, the mice were all given lymphoma cells, got human lymphoma, and died. Then a second group of mice were given lymphoma cells and were first given a single dose of an endorphin called beta endorphin. And half of the mice then, when given lymphoma cells, did not get lymphoma. The other half did, but it grew much more slowly than in the first group. And the researcher who did the study speculated that the endorphin that he gave was working on the cancer by directly affecting opioid receptors on the cancer cells. which are the receptors for endorphins, as they are for heroin and morphine-like painkillers.
Excuse me, you said just a single dose?
Yeah, just a single dose given in the abdomen.
But then that's out of the system very quickly, right?
Yeah, in the mice it was, but that single dose was enough so that when the tumor cells were injected into the mice shortly after that, they didn't take in half the cases. And in those who did, the cancer had been modified enough so that it grew much more slowly.
With just a single exposure, that's it.
Yeah, with a single exposure. Since then, there's been a lot of research studying the relationship between endorphins and cancer in laboratory animals and in the test tube. And there's a large number of studies. And the studies have involved giving beta endorphin, the endorphin from the pituitary gland, metenkephalin, an endorphin made in the adrenal gland, and low dose naltrexone. And the low dose naltrexone works by inducing the body to make more of both endorphins, and so that they work similarly to the direct injection of endorphins. And all three are effective in markedly reducing the number of cancers that take in mice, or once the cancer has been injected and started growing, in producing remission. And that's been true with almost every cancer that has been studied in mice, with pancreatic cancer, colon cancer, cancer of the head and neck, lymphoma, Hodgkin's disease, and a wide range of malignancies that have been injected into mice. And the person doing the bulk of that research, investigator doing it, who's a PhD, believes that all cancers have opioid receptors. He's gotten responses with all the cancers that he's treated with endorphins or low-dose naltrexone in laboratory animals. The question arose as to whether the effect on cancer was a direct effect of the endorphins on the tumor, or work through the intermediary effect on the immune system, because it's well known in scientific circles that endorphins boost immune function. And in order to separate that out, he did 2 studies in which he grew cancer cells in the test tube where there is no immune system. One was colon cancer and the other was pancreatic cancer. And in both settings, the cancer was grown in a nutrient solution, and the cancers were growing rapidly, and adding small amounts of metenkephalin, the adrenal endorphin, to the actually a petri dish in both cases, led to cell killing and cancer cell death. Both cancers were destroyed by the endorphins. So in that case, there was no immune system intermediary, and that supported his belief that the endorphins work by activating the opioid receptors and producing what's called apoptosis, which is the term for pre-programmed with programmed cell death, induced in this case by endorphins, primarily cell death that occurs while the cells are dividing. And of course, cancer cells divide much more rapidly than any other cells in the body. It's curiously, chemotherapy works also through apoptosis, through a different mechanism, not through the opioid receptors, but mostly on the cell nucleus through other intermediaries. One major difference is that since chemotherapy works primarily on the DNA of the cell as it's dividing directly, it also works, besides on cancer cells, it works on other cells of the body. So the chemotherapy side effects are all related to effects on the more rapidly growing cells. That's why there's hair loss, and that's why the white blood count drops, because both involves tissues that are growing more rapidly. Nails stop growing during chemotherapy. Metcalflin or beta endorphin or low dose naltrexone, by raising endorphins, work in these animal settings directly on the cancer cell. And since the endorphins are hormones naturally present in the body, they don't have the same side effects. In fact, they basically have none. One of the factors involved is that all the studies that have been done that I'm aware of endorphin levels in people with cancer show that endorphin levels are quite low, generally less than 30% of normal, just as they are in people with AIDS. And so the hormone that the body most needs to fight the cancer is lacking. Giving endorphins or low-dose naltrexone to raise endorphins serve as means of restoring normal endorphin levels in people with cancer. And that appears to have the possibility of producing remissions in some cancers. Even restoration to relatively normal levels may well do that. One of the implications is that one of the causes of cancer may be a drop in endorphin levels, that the endorphin levels may first drop, and by dropping, deprive the body of its most important defense against cancer, which is direct cell killing by endorphins. Indirectly deprive the body of another defense against cancer, which is through immune system cells called killer cells, natural killer cells, and what are called CD8 cytotoxic killer cells. Both are low when endorphins are low. Both are enhanced by the presence of normal levels of endorphins, as are all immune functions. And so a drop in endorphins would reduce the immune system's surveillance against cancer and its ability to kill cancer cells as they arise. And the lack of endorphins would also deprive the body of the direct cell killing effect on cancer cells of endorphins. There's been some studies that don't completely tie up the answers to this, but raise possibilities that might explain it. A number of studies have shown that cancers frequently arise after periods of grief. For example, the point in life at which the risk of cancer is the greatest is a year after the death of a spouse. The rate of cancer development 12 months after the death of a spouse is the highest of any point in one's lifetime. Also, cancers are more frequent as people get older, and that's probably both because of a decline in immune function as you get older and a decline in endorphin levels as you get older. There's also been some studies, not as easy to prove, but that suggest that cancer often arises from 1 to 4 years after a period of sustained chronic stress, which eventually lowers endorphins. And to the extent that chronic stress plays a role in cancer development, it very likely does through the intermediary of reducing endorphin levels and thereby depriving the body of its defenses against cancer.
Now, as a layperson, we're always hearing about endorphins that's related to exercise.
Right.
Is that the normal way that we can boost our...
That's a very good way to boost endorphins and boost immune function. And there's no question that people who do aerobic exercise, the kind of exercise associated with cardiovascular fitness, does raise endorphins. That's been demonstrated. One interesting study was carried out in San Francisco in people with AIDS, who were, all of whom were going to gyms, and they were divided into two groups. The people, and they're all men who went to the gym regularly just for bodybuilding purposes and did relatively little aerobic exercise, and men who went to the gym on a regular basis to do aerobic exercise with much less attention to body building and weight training. And both groups had AIDS. Both groups started out with the same level of disease progression, and over a 5-year period, the death rate in the group who were going to the gym for bodybuilding was double that in the group who was doing aerobic exercise. The number of opportunistic infections, those serious infections that kill people with AIDS, was much higher. And it wasn't because of a harmful effect of bodybuilding, it was rather that the aerobic exercise, by raising endorphins, strengthens immune function and thereby helps to sustain the immune system's ability to fight HIV. That's the one study I know of that's closely tied exercise to better health or reduced disease in a disease that is associated with low endorphins.
Now, I noticed in some of your pamphlets out there that actually higher doses of naltrexone can promote tumor growth?
Well, I only know that anecdotally. For example, I had one patient with AIDS who developed a lymphoma, was on naltrexone and other drugs that are antiviral drugs against the virus, and without any specific treatment for the lymphoma was stable for 3 years. And the mail order pharmacy he was getting the low dose naltrexone suddenly started sending him 15 milligram tablets instead of 3 milligram capsules. And within 8 weeks, his lymphoma started growing, and he died within 6 months. And it happened simultaneous with the employment of a new pharmacist who didn't understand that naltrexone came really in 2 doses, or should be used in 2 different doses, and gave him the wrong dose mistakenly.
And he didn't realize it?
He didn't realize it, and I hadn't seen him for some time. He had moved away from New York and then came back as he got sick again, and came to see me and discovered this at around the same time. And he'd been on the 50 milligram tablets for about 4 months, and his cancer had started growing again after about 2 months on the high dose.
And did he start exhibiting the other side effects from high dose?
Yes, he had depression, insomnia. He assumed these were all due to other things going on in his life and due to the fact that he had AIDS. But in fact, as soon as he dropped the dose back to 3 milligrams, those side effects disappeared. But his cancer was now growing very rapidly, and he was given some chemotherapy, but it didn't work, and he died within about 6 or 7 months after this change in dosage. Beyond that one experience, I don't have definitive evidence that high doses would accelerate cancer growth, except that if what I've been saying is true, that endorphins play a major role in the body's defenses against cancer, then blocking them would do the same as depriving one of endorphins. You block them completely. So it makes sense, theoretically, that high doses would accelerate the development of cancer. Nobody's seen that. Nobody's tried it, obviously. He tried it purely accidentally.
Now, wouldn't he have been a prime candidate for the meta-enkephalin?
Well, metenkephalin might have been useful for him. wasn't really available. Theoretically, it's not now. It's at the moment not a licensed drug any place in the world. There have been several studies under FDA approval in the past of metcalflin in people. There were a series of studies of metcalflin used to treat cancer, each for short periods of time in individual patients. But in each case, there was only enough metcalflin to treat people for 3 or 4 months, enough to identify that there was some improvement. Then in 1990, the company that was funding these studies approached me to do a trial, with a formal trial with metcalflin as a treatment for AIDS and HIV infection. And I did. We did a placebo-controlled study of metcalflin given intravenously 3 times a week to people with HIV, all of them in the middle range of T cells. They didn't have an AIDS diagnosis, but were just short of it. And in the course of the study, people's immune function improved significantly, and there were no side effects. The only time that we had a side effect was on one occasion when the research nurse working with me gave the infusion too quickly, the intravenous infusion, and the patient started sweating and had a slightly rapid heartbeat. And we just lay him down, and he was fine in about 10 minutes. That's the only time it ever produced side effects. Right now, there's only one very small study going on with FDA approval of pancreatic cancer by a research group in Hershey, Pennsylvania. And so far, they've started 3 people on metcalflin, giving it once a week in very high doses. I don't have any idea as to what they're seeing. But it is the same institution where all the animal studies that I described were done. And clearly Dr. Zagon, the PhD who did the animal studies, arranged for this trial. As a PhD, he can't run a clinical trial, but the 2 oncologists at his institution at Penn State their medical school in Hershey, Pennsylvania, are doing this trial. There's no other trials going on now. Unfortunately, the company that funded the trial that I did in people with AIDS was not willing to continue funding an expanded drug development, although the FDA was quite interested. And that they actually used the results from the trial I did as a basis for identifying that drug as safe and non-toxic. But it was around the same time that several large drug companies were developing antiviral drugs for HIV, which have since come out, have been quite successful in affecting the course of HIV and AIDS. And I assume that the small drug company involved was not prepared to compete with those at that point. So at the moment, there's no research at all going on in people with AIDS with metcalflin, and the only research going on in people with cancer is this study in Hershey, Pennsylvania.
How many people involved in that study?
So far 3. I don't know how many they plan to do. It's being funded by the National Cancer Institute, and I believe the amount of money is not on the order of funding that usually is supplied by drug companies that are investing in a drug based on patents and expect to make a lot of money from it, or hope to make a lot of money from it. It's a small study funded by the National Cancer Institute, which has funded all of the research that Dr. Zagon has done up to now. So they're interested enough to fund this small trial.
Now, the study that you did was really just to determine which is the correct dose when you're working on the low dose part of it.
Right.
And tell me how many people were involved in that and why was it so expensive?
Well, there were 50 patients involved, and 51, I think, by the time we stopped it. And a third of the patients got a low dose, a third got a higher dose, and a third got a placebo of metcalflin. And it was expensive because clinical trials are very expensive. They involve, in this case, they involve visits to the research center 3 times a week with several staff members, myself, another physician, research nurses. They involve the cost of the infusions, the cost of the drug. They involved the data collection and the expense of filling out all the forms and of analyzing the results. Clinical research is extremely expensive. That trial actually cost about $600,000 with just 50 patients. So a study large enough to demonstrate whether or not metcalflin would work for AIDS or for cancer would cost in the range of $10 to $20 million. Now that it's been demonstrated as being safe and non-toxic, it would still cost at least $10 to $20 million to do a large enough number of patients. The expenses of that kind of research are enormous.
Now, you don't really need to do a study since naltrexone is illegal.
Yeah, naltrexone is a licensed drug. Since it's a licensed drug, physicians are allowed by the FDA to prescribe any licensed drug for what they call an off-label use, in which the drug is approved for one purpose but used for another. And there's a large number of drugs that are used in that fashion. A lot of the drugs cardiologists use, for example, were discovered to work for high blood pressure, and once they were licensed, also were discovered to work for heart failure and for angina pectoris, chest pain from coronary artery disease. And so the drugs the cardiologists use, cardiologist friend of mine said about 60% of the prescriptions he writes for heart patients are for off-label uses. In those cases, it's usually for the same dose. In the case of naltrexone, the dose we're using is 3 milligrams a day, so it's for a much lower dose. So the off-label use is legal and medically acceptable. That doesn't mean that the drug has been demonstrated to have efficacy or effectiveness for any of the diseases. It would require large trials done under FDA auspices that were large enough to prove statistically that the drug works, with the goals of the trial being in AIDS. It would depend upon the particular trial, but the goal would probably be to markedly reduce the level of breakthroughs against antiviral drugs, breakthroughs in virus growth. And in various kinds of cancer, the goals of the trials would be survival, regression of cancer, and so on. And you'd need a large number of patients for each trial, for each use. Probably cost $10 or $15 million per study. So if you studied low dose naltrexone for several kinds of cancer, each study would cost several $1 million. The AIDS study would cost at least $10 to $15 million at a minimum.
And once this study is done, I mean, that basically gives you the rights to claim it?
Well, once the study's done, if the trial is large enough to show efficacy or effectiveness, and the FDA decides to license it based on a trial, such a trial, that they would play a role in proving the design of, then it would become an officially licensed drug at 3 milligrams for that particular purpose. And I work with closely over a period of several years in developing the Low Dose Naltrexone were two researchers named Vincent Ragon and Finvola Jury. And unfortunately, they both have died since. I'm working with other people now, but they were key to the drug's early development.
What did each do?
Well, we worked together in designing the trials. They were always present at the research center where the studies were done, and helped collect the data. And it was basically the research design that was most important, and the conceptualization.
Now, why? I'm sort of surprised that Vincent died. I thought this would have kept him going.
Didn't. Actually, the one complication of AIDS that naltrexone doesn't seem to prevent is AIDS dementia. And some of the newer antivirals are very helpful for it. And I'm actually right now using one of the new Alzheimer's drugs, which are quite successful in treating AIDS dementia, or now called HIV encephalopathy. And but the naltrexone, which he took as he got sicker, he never had problems with opportunistic infections, and his T helper cells, which are the key immune system cells in the disease, never dropped. But the HIV encephalopathy was not prevented, and he eventually died of that.
Now, you mentioned doing tests to determine someone's endorphin level.
Well, there's no good commercially available test for endorphins. We did, however, hire a research laboratory scientist to run endorphin levels for us. And there was, as I remember, a kit that the scientist had to purchase to do each endorphin level. They're quite expensive. We ended up doing endorphin levels in 10 people with AIDS, and then that was 10 tests. We then did levels the day before starting naltrexone and the next afternoon in 10 people with AIDS, and did the same in 10 people who didn't have AIDS to demonstrate whether or not endorphin levels rose, which they did, 2.5 to 3-fold. And the total cost was about $50,000, just for less than 50 blood tests.
Would the blood tests have to be done in the middle of the night?
Well, the blood would have to be drawn. Actually, the best time to draw the blood would be in the afternoon at the same time every day, and draw the blood before starting naltrexone, and then draw the blood 2 or 3 days later at the same time in the afternoon. It's not necessary. Ideally, if I had the funds, I would do it in a sizable number of people. I might try to do that in people who are, for example, aren't doing as well as I'd like to see if they're responding as well as someone else, if there might be some small dosage adjustment that I would make. It is clear the dosage range is no less than 1.75 or 2 milligrams, and no higher than 4.5 or 5 milligrams. So the range is really at which it works is between, I'd say, 1.75 and 5. 3 is a good dose that covers almost everybody.
So what happens over 5?
Well, as the effectiveness is reduced because you have a longer period of blockade of the endorphins. And the more you block the endorphins, the less time you have for the endorphins to do their job. So the ideal is to find a dose. The ideal would be to find a dose for each person that maximally increased endorphins and minimally block them. And it is clear that that's the dosage range, and it might be useful eventually to do endorphin levels to find out where within that range somebody falls. Or alternatively, the way medicine is practiced, we usually give standardized doses of drugs, to give a standardized dose, and then for people who are not responding, or not responding as well as we would expect, to measure endorphin levels at different doses and find out if there's another dose somewhat higher or somewhat lower that would work better. But the range would be about the same. It's a very small window of dosage.
I'm a little confused about the blocking mechanism. I thought it basically, the naltrexone stimulated endorphin.
Well, it stimulates by blocking. It blocks the receptors for opiates, for endorphins, in the hypothalamus, a structure in the base of the brain. And when it blocks those, the hypothalamus begins producing larger amounts in the middle of the night of a complex pro-hormone called pro-opiomelanocortin. That's a hormone that breaks up eventually into 3 hormones, goes down a small stalk into the pituitary gland during the night, and in the pituitary gland it's broken down by enzymes into beta endorphin, a hormone called ACTH, and melanin stimulating hormone. And so that we know for sure. It also induces the adrenal gland to make more enkephalin through a prohormone called proenkephalin. But it causes the increase by blocking. What the blocking does is it gives the body a false message that the body doesn't have enough endorphins. And so the body responds with exquisite sensitivity by making more. The body's able to overcome an incredible number of... This is a foreign substance, and yet this foreign substance induces the body to make more of a natural substance in the body. And so it works by blocking, but by blocking it induces an increase in endorphin production. That's why the dose is so critical, because we could just give everybody 50 milligrams and get a good increase, but the 50 milligrams would block the endorphins and they wouldn't do any good. And so the ideal dose would be the dose that produces a maximal increase but a minimal blockade of endorphins in the periphery.
Now, when the endorphins are stimulated in the middle of the night, does that level stay through the day?
Well, the beta endorphin, we know does. Beta endorphin has a very long life in the body. The term is used with hormones and with drugs of half-life, which means how long it takes for half of a substance, a hormone or a drug, for the body to get rid of it, for it to leave. And the half-life of beta endorphin is around 20 hours. That means if you raise beta endorphin levels between 2 and 4 in the morning, you still have much higher levels all the next day, into the next evening. Metenkephalin is harder to measure because when it's produced, unlike beta endorphin, it immediately goes into cells. It stimulates the opioid receptors and goes inside cells. The levels that we measure in the blood are not as reliable because of that the next day. Presumably the cells of the body contain larger amounts of metenkephalin, but you wouldn't be able to tell easily by doing blood levels. Eventually I hope that we can.
Now, you see a synergy and a two-prong attack effect with using metenkephalin?
Well, potentially. There could be a value in using both together. the naltrexone would work by getting the body to make more endorphins, make both beta endorphin and metencathalin. And of the two endorphins, those are the two commonest endorphins. There are others. There's an endorphin called dynorphin, whose functions are less clear, present mostly in the testicles. But the two most important ones for enhancing immune function and for killing cancer cells are endorphins that have what are called delta opioid receptor effects. There's several different kinds of opioid receptors. The mu receptors are the pain receptors. Mu, named after morphine. Those are in the brain. The delta receptors are the receptors present primarily small amounts in the brain, but present in many tissues in the body, most tissues. The delta receptors play very little role, if any, in pain relief, but they do play a major role in not only controlling cancer, but in many of the effects that I described before that endorphins have. For example, the receptors in the immune system cells are primarily delta receptors. So most of the peripheral and systemic effects of endorphins are mediated through the delta receptors. The receptors for dynorphin are called kappa receptors, the ones in the testicles. And it's not clear what they do. There's actually one endorphin receptor, the kappa receptor, that also seems to be the receptor for the drug PCP, and is present in the brain. And when PCP is a hallucinogenic drug, and what the relationship is between that receptor, brain function, and endorphins is very unclear. But there is one opioid receptor that is specifically responsive to PCP. And there's some evidence that endorphins may play some role in controlling psychosis. I've actually seen examples of it. So that probably involving the PCP receptors, especially when I was treating a lot of methadone patients. When people were slowly taken off of methadone, about 3 or 4% become psychotic as the methadone dose is reduced. And for those people, there tends to be a critical dose of methadone that prevents the psychosis. When you drop below that dose, it appears. And so below a certain dose, generally in the 5 to 20 milligram range, people would begin hearing voices, seeing things, have very disturbed thinking, and develop, in some cases, all of the symptoms of schizophrenia. Those are people who had to stay on methadone. Now, if methadone in those patients relieved their psychosis, it may well be that methadone has some effects on the receptors, the PCP-related opioid receptors, that in its absence, those receptors are too active and produce psychotic symptoms. And in its presence, they're suppressed. But that nobody's done a lot of follow-up research. There's been some interest in it, in investigating that relationship, but not enough, I think, to demonstrate what role endorphins and opiate receptors play in diseases like schizophrenia. And they clearly play some role in some patients, some people with schizophrenia.
So what kind of numbers are people who are using naltrexone right now?
As far as I can tell, mostly by calling pharmacies around the country, there's somewhere between 30 and 40,000 people on low-dose naltrexone. From conversations with the pharmacists and with physicians who are using it a lot, about 2/3 of them are taking it, are using it for treating HIV and AIDS. And in particular, more recently with the purpose of trying to prevent or treat a complication of one of the family of antiviral drugs for HIV called protease inhibitors. It's a complication in which fat metabolism is disturbed and fat redistributes itself so that people's bodies become very distorted in shape, and their blood cholesterols and triglycerides go sky high. There's a disturbance in all aspects of fat metabolism. And naltrexone appears, anecdotally in my practice, to prevent that complication, because not a single patient who I've treated with these new drugs, and there's nearly 200 who are also on naltrexone, has gotten that complication, while around the world about a third of people on those drugs get the complication within a year. So that does strongly suggest that it prevents it. Also, 4 of my patients with AIDS or HIV who were taking naltrexone with new antiviral drugs stopped the naltrexone after starting the new antivirals, and after they saw the dramatic effects of the new antivirals. All 4 developed this complication, which is called lipodystrophy. And generally 7 to 10 months after stopping the naltrexone, all 4 resumed taking it, generally after calling me, and 2 of the 4 have had a complete reversal of this lipodystrophy. A third one has had about a 70% reversal in the first 7 months, and the fourth one has had no more than about a 20% reversal after a year. So 3 out of 4 have had a good response to, in terms of clearing up of this complication.
So it's 30,000 people, and you said 2/3.
About 2/3 seem to be taking it for HIV. Others are taking it to treat various kinds of cancer, autoimmune diseases. Primarily those 3 families of those 3 kinds of disease.
Now, how does it function in the autoimmune?
Well, I can only guess, but I've certainly seen a number of people with autoimmune diseases who respond to it. And what is clear is that the immune system's harmony and orchestration is disturbed in autoimmune diseases. What tends to happen in a large percentage of autoimmune diseases is that the T helper cells, which are the ones that are most vulnerable in HIV, are impaired in their function. Their numbers don't drop substantially, but their function is impaired. And they're really the master cells of the immune system. They're the ones who orchestrate the actions of the others. When they aren't functioning well, one of the functions of other immune system cells that's very important is lost, and that is the ability that the immune system has to distinguish between those chemical structures in the body that are me, that belong to the self, and those that are foreign to the self. It's that ability to distinguish between self and non-self that allows the immune system to recognize bacteria as foreign and attack them, or parasites or funguses or cancer cells, which mutate enough so that they become like foreign. They become foreign, as foreign almost as bacteria or funguses, and become the object of attack by immune system cells. What happens apparently in many autoimmune diseases is that some of the immune system cells, in particular cells called macrophages and cytotoxic killer cells, lose the ability to make that distinction, usually with regard to one, sometimes more than one system of the body. And they start attacking the body's tissues. In multiple sclerosis, for example, the killer cells or macrophages start attacking the myelin sheaths, which insulate nerve fibers. And it's the attack of the immune system on the nerve fibers that causes the neurological impairments in multiple sclerosis. And there does appear to be significant benefit to using low-dose naltrexone in treating multiple sclerosis in terms of preventing further attacks or progression. And I assume, based on this kind of research, that it's working by enhancing the functioning of the T cells, thereby restoring the proper orchestration of immune function, thereby stopping the attack cells from attacking the insulation of nerve fibers. But it seems to work quite well in a range of autoimmune diseases, lupus, rheumatoid arthritis. That's just anecdotal. None of these things have been demonstrated in large clinical trials. But there appears anecdotally in my practice to be good responses to the drug in diseases like asthma, which is partly autoimmune, eczema, which is entirely autoimmune, psoriasis, which is an autoimmune disease, and several other less common autoimmune diseases show a good response. And although I haven't had the opportunity to do endorphin levels in people with those diseases, I assume they're low. And that because it appears that restoration of normal endorphin levels causes reversal of the disease process.
That you would be very sort of frustrated at having this great drug and not really being able to get it out to everybody.
I am, no question. What I'm frustrated about is not having the funds to do the proper clinical trials. And what I'm doing about that is to negotiate with drug companies that show some interest. And the drug companies would say, if I find a drug company that is prepared to do the work involved and put up the funding involved, drug company would do clinical trials under FDA guidelines for each disease that the drug appears to be useful for. And once the drug was shown to be effective, if it is effective for each disease, the FDA would license it, and then it would become a licensed drug at 3 milligrams for that particular purpose. But doctors would also would be able to start using it for off-label uses at use the 3 milligram capsules for other diseases too that they very likely would realize are related to the disease that it's approved for, if it is. It's very frustrating to me, because from my own experience, it seems to me pretty clear that the drug has a lot of value, but it really doesn't in a formal way, and in a way that other physicians will lead other physicians on a large scale to pick up and use it until it's been officially approved by going through this process. And that is frustrating, that it takes a long time to find the right company to partner with to develop it.
You don't think there's any possibility to some sort of benefactor like Bill Gates or someone?
Well, he would have the money. I calculated that doing the first 3 trials would cost about $50 million. But you would then need a company that has the capacity to not only test it, but to work with the FDA, to follow their guidelines, to bring it through the approval process, then to manufacture it, distribute it, advertise it. And only drug companies and biotech companies have that capacity. So funding could come from outside, from venture capitalists, or even people like Gates who set up large foundations. But eventually the money would have to go to a company that has the capacity to take all those steps and do it well.
It seems to me if you got the word out about these 30,000 people that are involved with this, that they would start to have some effect just on its own.
Well, it does. I mean, the word is spreading a lot through the internet about it, and a lot of people are trying it. In many cases, most cases, getting their own physicians to prescribe it, because I certainly haven't prescribed it to 30,000 people. I have perhaps 800 or 900 right now that I'm following on it at the most. So a lot of people are on it through their own physicians. And one of the things that makes it easy for physicians to prescribe it once they read about it and think about it is that the toxicity is really zero. It has absolutely no toxic effect at all, no side effect on a short-term or a long-term basis. So there's no downside to it. And it's quite inexpensive. Most pharmacies charge $25 for a month's supply. So it's not toxic to the pocketbook either.
But that also mitigates against the drug company wanting to get involved.
Well, if a drug company got involved and got it approved at 3 milligrams, that would become the official form. And that would be the dosage and product that insurance companies would pay for. They wouldn't pay for a pharmacist to grind it up and make 3 milligram capsules. They would only pay for the officially approved drug manufactured by such and such a company. And so if it does go through trials, the companies I've talked to all agree that that would not be a major impediment. What probably would happen is the vast majority of people taking it would take the 3 milligram capsules made by the company that owns it through the licensing, and only those people who don't have insurance and would have to pay larger amounts for the drug, because the price might go up, would certainly go up, I think, from the current pharmacy price, would be those people who have no insurance, to whom it would be cheaper to have a pharmacist make it up. And it doesn't matter to them whether, because they're not going to get it paid for one way or the other. That probably would amount to 10% of the people taking it. So if 90% of the people taking it are taking it in the form in which it's been approved, made by the company it's been approved for, then the company will make lots of money. That should not be an impediment.
It almost seems to me like you're in a position where you could actually sort of avoid the whole FDA thing.
Well, the problem is...
It is a legal drug.
Yeah. I mean, people could avoid it and do, since it's legal for doctors to give it now, but it's not going to be universally used for any disease until it's licensed. Most physicians are not willing to. And also until it's shown in really good scientifically designed studies to work, only then will it become widely known, widely understood. Only at that point, not only would physicians prescribe it as a routine for those diseases it works for, but the follow-up research would be done to identify how it works, what it does, and what other diseases it might work in. At the moment, it's sort of a haphazard system in which it's not really been proven that it works for anything, except at high doses. And although it appears to have some benefit at low doses, it really has to be proven in a scientific way. And I understand that because I'm a scientist. I've done sizable numbers of clinical trials. And although I've used other drugs off-label for patients, I'd rather give drugs that have gone through scientific study to people. I wouldn't hesitate to give a drug like this in a smaller dose that's already licensed. It's just a matter of that the licensing by the FDA would not only make it immediately available to everybody, it would lead to insurance reimbursement, it would lead to physicians understanding what it's useful for, it would lead to more studies, and probably studies to extend its uses to other things that I'm not even aware of, if it does turn out to work in these trials.
Well, so, I mean, you're in a position of searching for a drug company partner.
Right, yes. Right now, I'm looking for a drug company to negotiate with the purpose of having the company make a commitment, a contractual commitment, to do clinical trials for HIV and AIDS, for at least 2 or 3 kinds of cancer, for autoimmune diseases, and to make a commitment to carry each use if the drug is licensed, if the trials show effectiveness, to develop it for each use, and then to market it, manufacture it, market it, and distribute it, and to contract with me so that I can license my patents to them, so that they would be in a position to make a sizable enough profit to make their investment worthwhile.
What kind of percentage of what kind of success do you need in a trial to be able to?
Well, the general standard is that the drug needs to be at least 5% better than a placebo.
That's all.
Yeah, that's all. A lot of drugs have been approved just with that small difference. And actually, usually the clinical trials are designed with the assumption that it would be 5% better, with a large enough cases to demonstrate that, a 5% difference. Once you have, the drug may well have more than that a degree of effectiveness, but the standards really are 5%. Particularly in a drug that has little or no toxicity, like this one.
The feeling I get from talking to you and you're reading your research is you're sort of in the 60–70% of.
It certainly seems that sounds about right. Certainly with the results I'm getting, combining it with antiviral drugs in people with AIDS, in treating people with cancer of various kinds with it, in treating people with autoimmune diseases, it looks anecdotally, and from a perspective of a private practitioner, it looks like that's about the level of effectiveness. That's not a bad stab at it. But
you should actually you should say the percentage, because I don't want to use my
okay,
question.
okay, probably overall an effectiveness of 50 to 70%. But that's just my that's my impression. And unfortunately, being the developer of this, I don't know how biased I am in my observations, nor does anybody else. And so this kind of anecdotal information can't ultimately serve as the basis for licensing. It really requires that the trials be done by somebody else in each field, for each disease, by people who are specialized in that field, in that disease, and who also have had experience doing research in clinical trials for that disease, and people who have no financial investment in it, which obviously I do. That would provide much more credibility for the results, which my results lack, since of the way I'm involved, the nature of the way that I'm involved with it.
Now, you're also using it for hepatitis C.
Yes, I am. With hepatitis C, it's hard for me to identify how much it does, because I'm using it in combination with a purified extract of the St. John's wort plant, in which an ingredient called hypericin has been extracted from the St. John's wort and added back in about 22-fold. So since this hypericin in the test tube is extremely effective against hepatitis C and hepatitis B, I had a company make this concentrated form up to use in treating people with those 2 kinds of hepatitis. And the combination of that with naltrexone looks very promising. And actually it looks like to me like the hypericin the concentrated St. John's wort is probably the more important of the two ingredients. I think the naltrexone is helpful with any chronic infection, but the more dramatic element here is the hypericin, because in the test tube it really suppresses these two viruses. And in people it seems to suppress hepatitis B and hepatitis C growth and markedly improve liver functions.
And then naltrexone is sort of an all-purpose immune system.
Right, and the naltrexone is should be useful in treating any chronic infection, tuberculosis, for example, Lyme disease, any certainly diseases like genital herpes, which I do have a patent for, and it seems to be effective in people infected with genital herpes in preventing recurrent attacks. So by boosting immune function, it appears to have benefit in a wide range of infections by increasing the immune system's ability to control them. The hepatitis C, it's hard for me though to separate out what it does in hepatitis C because the hypericin acts as an antiviral and is quite effective.
Well, you know, the more I learn about this, it seems like it should be sort of just like a vitamin for everybody. I mean, as a prophylactic.
It also could be viewed as a kind of snake oil. That's the concern I have, is that, you know, when you start talking about a drug that has such a wide range of potential values, sometimes people think you're a snake oil salesman, and I'm really not. Each one of the things that I use it for involve diseases I've been treating for a long time, and I've collected data as carefully as I can in my practice, and it looks very promising for many things.
And tell me about you yourself and your family take it.
Yes, I've been taking it for several years because my grandfather died of colon cancer. My wife takes it because of a very strong family history of breast cancer. We have a number of friends who take it because of family histories of cancer, because it seems intuitively obvious that to them, as it does to me, that a drug that would effectively treat cancer should also help prevent it. Proving that would be a massive effort. You need to follow 50,000 people for 5 to 10 years who are in high-risk groups. But one of the likely off-label uses, once it's approved, will be by people who realize intuitively that it works, it should work to prevent cancer, and who start taking it for that purpose.
And there's no reason that you've come up with to not take it?
There's no downside to it. Of all the people I've given it to, first of all, when other physicians use it, if they run into what they think are side effects, they always call me, or the patients call me, because my name is so associated with it. The only side effect I've seen is a very small percentage of people who find that on 3 milligrams their sleep is poor, and all that they need to do is to lower the dose. Simply means that that dose is too high for them, and because they're more sensitive to it. And generally lowering it to 2 milligrams is enough, to 2 or 1.5 is enough to eliminate the sleep disturbance. That's literally the only side effect that I've seen. And I've had 2 women on it for 14 years, one with multiple sclerosis, one who had a metastatic melanoma and has been in remission, and they both have stayed on it simply to make sure their disease doesn't recur. And they've had no side effects at all. I've been on it for about 10 years, my wife for close to that. I've had a number of AIDS patients on it for as much as 12 to 14 years with no side effects at all, no downside to it.